This is a story of a man who went to pick up his son who was doing MSc chemistry, and when he was closing down the experiment, something went horribly wrong. So the father got the worst part of the injury, and the son also got some injury in the eyes and in the face. You can see both the eyes are damaged, and this is basically this particular patient was the very early in my career in 2001 when I started doing the ocular surface. You can see both the eyes. There is hardly any light perception. The destruction of the skin and the eyelids, and the left eye was almost auto eviscerated. Right eye, there was some evidence that there is a cornea, but there is no other structures which is visible. Um, After doing initial treatment, after surgical treatment for the skin lid by Dr. Santosh Sonawar, and then stem cell transplantation, direct limbal transplantation from both of his sons with systemic immunosuppression, we could bring him to a level of 20/100 vision with N6, which lasted for about 10-12 years. And after that, he underwent another the K-Pro, and that continued for another 10 years. This is a story of a young man from Gujarat who underwent LASIK surgery in 2006-2007, and he used to work in London. After 10 days, he develops this infection in that eye, and this is fungal keratitis. He was advised to remove the flap, and then he came back to Ahmedabad in India, and there also doctors were not very sure what to do. So he came, landed up with us in LVP. So we did a large therapeutic graft followed by then we were doing autologous cultivated limbal epithelial transplantation, or CLAT. So this followed by a cataract surgery and a corneal transplant, we could restore a vision of 20/50, 20/40 in that patient. So when you see these extreme cases, it does not mean that nothing can be done. There is a possibility, there is a hope. And that hope is brought by the stem cells, which we have been using for for last 20-25 years now. And for normal ocular surface, we need three elements: preocular tear film, surface epithelia, ocular sensitivity. And all these have been covered in the morning. What the limbal stem cells are, how they function, we covered in the morning session very nicely by the speakers. When you have deficiency or destruction of the limbal stem cells, what you get a disease called limbal stem cell deficiency, and that is because there is a molecular barrier is broken. The stem cells can be deficiency can be primary or secondary. Most of the patients that I have been treating are chemical injuries, VKCs, OCP, and Stevens-Johnson syndrome, and I read a little bit. These are symptoms or clinical features in the form of a recurrent epithelial defect or PEDs. There can be conjunctivalization, which is very evident clinically. How you diagnose limbal stem cell deficiency? Very simple clinical diagnosis, that you do a slit lamp by microscopy carefully, and you do fluorescein staining. And if you are doing some research, you may want to do impression cytology, but clinical diagnosis is good enough. Then further, if you have diagnostic equipments like anterior segment OCT and IVCM, they can give you little more further details. But for routine clinical management, I do not use any of these diagnostic modalities. The management or the definitive management of limbal stem cell deficiency is some sort of limbal stem cell transplantation, and the blindness due to LSCD cannot be treated by keratoplasty. And for unilateral LSCD with wet eyes, the best treatment is autologous limbal stem cell transplantation. And for me now, it is a simple limbal epithelial transplant, which I'll share with you. For bilateral LSCD with wet eyes, I'm emphasizing the wet eyes because it's important to make a distinction. And there's a whole load of different options available for bilateral limbal stem cell deficiency. In 2001, we started growing the cells on amniotic membrane in LVP in the stem cell lab, and this is the technique of harvesting the limbal biopsy. We never used any of the allogenic material or genogenic material, and in about 2 weeks you get a monolayer that is ready for transplantation. This is the technique of how you remove the pannus, and this pannus removal is slightly technical because you need to have understanding how from where you start dissecting. You see, I'm very careful with 15 number blade going from the limbal area to central area, and once you dissect completely, you will see that this area, the cornea below, is very nice and without vascularization. And once you have removed this completely, then you bring your sheet of cultivated limbal epithelial cells, and in the beginning I used to suture it. After 2002 2003 I have been using the fibrin glue. This technique can give results like as dramatic as like this. This girl is from Bangladesh. We did a autologous cultivated, but vision did not improve. So we did a corneal transplant, and this is the histology of the same patient. And you can see this is a cornea which is multi-layered now. This is the same cornea. Because we transplanted monolayer, and there is a in vivo stratification which happens. Doing this technique, we did a very large number of patients, over 750 patients for autologous cultivated transplant in next 10 years, with excellent outcomes, which we have widely reported in the literature. Then we always wanted to, develop a technique which most people can practice, and not only a cultured stem cells. Can we have the audio, please? Can you switch on the audio? So this is a further simplification of limbal transplantation, a technique of growing the stem cells on the surface of the eye using the eye as a petri dish, and this is called. So you see, this is exactly the same technique that we do in the lab, that we grow the cells on the amniotic membrane. So after removal of the pannus, you put the explants on AMG and use fibrin glue, and then protect with the bandage contact lens. For beginners, the best case for SLET would be something which is a unilateral LSCD due to chemical burns, preferably alkali burn, and those patients who have undergone AMG in the acute phase with a good limbal palisades in the normal eye. You should avoid cases who are bilateral, who have immune mediated disease as a cause of stem cell deficiency, and the diseases which are like post OSS and excision are slightly more difficult, GVHD more difficult. This videos you have already seen, I will skip. So post-op, what you can expect in a patient with post-SLET. This is a autologous SLET, 3-year follow-up, and what you need is only topical treatment, like what you do for pterygium, steroid antibiotic drops, nothing more. And when you look at the follow-up, this is 12-year follow-up, the same patient, and this is another 12-year follow-up. So the results are very well maintained, and recently, and these are the confocal microscopy of 10-year post-ops. These are subbasal nerve plexus. This is a report published from LVP by the cases that we have done. There are 47 patients who had 5 to 12 years follow-up, and this is published in AJO early this year. What they've shown that the 70% of the eyes at last follow-up gained more than 2%, 2 lines, and their best achieved vision is 20/40. So this is a very good technique which now stood test of the time, and there is almost about 80 publication in the peer-reviewed literature on SLET for a technique which started in around 2012. In about 10-12 years, it's remarkable. This is a report that we published from Dr. Sarof Charity Eye Hospital in Delhi of looking at the stromal changes in post-SLET, and these are 40 patients who had at least 3-year post-SLET. And what we found that there is a on ASOCT, there is a thickness and reflectivity are objective markers of recovery of the post-SLET. Uh, Another unique application of SLAT is that when you excise OSSN, the OSSN oxygen, if it's more than 3 clock hours, will cause LSCD. So to prevent primary LSCD, you do a SLAT along with the OSSN oxygen, and this is a series published by Dr. Swati Kalki from LVP. Another unique application is acute chemical burn in a child who's 2-year-old, household cleaner, and this is what the eye looks like, and this is the post-SLET eye, the same child, about 20/40 vision, and this is pre-op. So, and this is the biopsy site. And this fact we published in journal Ophthalmology on 2016. We highlighted that the outcome of SLET in pediatric LSCD and adult LSCDs are very similar, and it was not that case in CLAT when we are growing the cells in the stem cell lab. Important benefit of SLET is that we looked at the economic, clinical, and social impact of SLET, and we found that there is a widespread pickup by different surgeons around the globe, and this technique has been replicated widely. Above all, the cost of surgery is at least 1/10 of the standard CLET it used to be. And this is the calculation, and these are based on the cost that what we calculated at that time in LVP and Dr. Saroff Hospital. There are some modifications of the technique because it's not a patented or it's not any IP protected technique, and different surgeons around the globe have reported different outcomes and different techniques. So there was a doctor from Bascom Palmer who was rotating with me in 2011. He wanted to replicate this technique. So his seniors were very scared that if we do SLET and if we don't cover these explants may fall off. So he devised a technique to put another amniotic membrane, and he called it a sandwich technique. And he did 6 cases, and they are reported in journal AJO, ocular surface, sorry. This is a technique where some surgeons had a feeling that it may fall off. So what they do is they put after cleaning the surface, they put the explant directly on the corneal surface, fibrin glue, and then put the amniotic membrane. So these are 2 case reports published. There was a doctor, there is one of my former fellows who is practicing his name is Vikas Mittal. He used no amniotic membrane. He said, if I don't want to use, what will happen? I said, try, and it may work very well. So he used in these 6 eyes published in Cornea that the SLET without amniotic membrane. Then I had a fellow from Russia, from Professor Boris Malugan's group. His name is Gerasimo, and he said, we don't have amniotic membrane, we don't have fibrin glue. So how do we do it? So they develop a technique of not using glue, not using amniotic membrane. And it's very nice, very novel technique. They make, after removing the pannus, they make peripheral pockets in the cornea with a crescent blade, and they stuff the explants there. And then it nicely covers, and these 2 reports published in Cornea. And can you have the audio, please? This is very nice, Professor Mulligan's video. Can you play the video, please, the sound? So now he has made this technique so advanced using a femtosecond, and all the steps. Is there somebody who can help with the video, the voice? Volume, please. So he essentially is showing in this video that he uses the femtosecond for all the steps, for harvesting the limbal biopsy, cutting into the pieces, and then making the pockets, and then putting those pieces like circumferentially, and uses no fibrin glue, no amniotic membrane, only a bandage contact lens. So for me, it is very satisfying that this technique, I wanted to develop a simple epithelial transplant. He has made it very, very high tech. And those of you who have less femtosecond machine and see such patient, you can, use this method. And now we are making surgery on the healthy eye. We mark the area of laser cut. And here you can see on the screen of the laser system the area of the cut. Gently separate each fragment with the microforceps and scanning intraoperative OCT help us to assess the quality of the cut. Projectile is placed forward and takes to the cornea. So he prefers to suture it. I use fibrin glue and put the flap back there after removing the limbal biopsy. They are now open spatula and little fragments are transferred on the surface of the cornea and placed inside the tunnels. Following that, bandage contact lens is placed. Here is the identification, before treatment, and 12-month surgery. Thank you very much. So this technique, now so many modifications from around the world, it's very heartening to see that. There are some of the complications. Any surgery we do, there will always be some complications. So they may be related to biopsy, they may be related when you are removing the pannus or related to amniotic membrane. This is like I would consider an ideal outcome when you have an excellent outcome and which stayed like this. You may have partial or focal recurrence, which is peripheral, like in the first figure. In the second, it's almost total recurrence, and the third is it's very bad. It has very thick pannus, and generally it comes if you're measuring your residual thickness of the cornea with intraop Pecchi, you can judge whether this will be successful or not. These are more severe kind of recurrence, but generally these things happen when you have a very severe damage to the ocular surface and there is no niche left or there is a ECM which is completely destroyed. How you deal with these recurrences? If it is peripheral, partial, like in this patient, I would not do anything as long as it's not obstructing the vision. If it's a complete recurrence, then I will see what was my observation during the first surgery. And if it's too thin cornea, the visual potential is limited, I may not repeat. Otherwise, you can repeat with or without LK. There is a residual scarring. You may have early or very superficial, which you can wait and it will recover generally. If it is deeper, it may not recover. So you may consider doing a DALK or a PK depending on the situation or depending on your comfort level. Say, for example, this patient who was July 2011 underwent a slat, and in August this is how it looked. Then about a year later, 6 months later. So at this stage I thought maybe I'll do a DALK, but patient was not very keen and he said, "Doctor, I had too many surgeries, now I don't want." So he kept coming every year. You can see that how it improves over a period of time. And this is the effect of the mesenchymal cells which are there in the explant. And now that science has been completely worked out by many people around the world, that these mesenchymal cells or the exosome derived from the mesenchymal cells are working and continue to work in the slat. So in summary, the cultivated limbal epithelial transplant did very well for many years. Some people may still want to do it, but for me, for last 15 years now, 13 years that I have not done a CLAT. I have been doing SLAT almost every week. I will do one or two, and this is a technique which is very, very robust. And these are some of the advantages of the SLAT, that it is very effective, it is replicable, repeatable, it's quite affordable and very reliable, that it works in all different situations, whether post OSS and excision, pediatric, LSCD, and it's an open platform technology. It allows surgeons to innovate and make it better for their situations. Thank you very much.
And now having celebration moment with Professor Sangwan. Please.
Thank you very much.
Thank you so much for the magnificent presentation in wonderful work, sir.